Well, we all know by now that mechanical ventilation can act as a double-edged sword. In many patients we need mechanical ventilation, also in patients that wean off sedation after surgery or cardiac surgery. But at the same time, while it's very helpful, it can also harm lung tissue. And this harming of lung tissue can translate in postoperative pulmonary complications, which in the end might harm the patient, longer stay in the hospital or even a longer stay in the ICU. Well, there are several things that we know by now. For instance, we should use a low tidal volume in our patients, but also have them wean as soon as possible, which means that we want to switch from controlled ventilation as soon as possible to spontaneous breathing. And that can give us an indication of early liberation from the mechanical ventilator, especially in these patients. Sure, I can. There are several things that you have to keep in mind. First of all, if you look at mechanical ventilation, in the old days we used a complete controlled way of mechanical ventilation. And there are already spontaneous modes of mechanical ventilation for a long time. But this automated mode goes several steps further. It automatically switches to spontaneous breathing, but also keeps the tidal volume under control. It's seeking actually for the best combination of tidal volume, a low tidal volume, and an adequate respiratory rate. And next to that, it's also keeping patients in safety zones with regard to their SpO2, so the oxygen level, as well as the carbon dioxide level. So it's keeping the patient in a safe mode, trying to wean as soon as possible in the most safe way with use of low tidal volumes. So this trial in approximately 200 patients, in which we had one group of patients being treated or ventilated by well-trained nurses and a group of patients in which the automated mode was working, we saw that breath-by-breath analysis showed that the patients were in a safer zone with the automated mode of mechanical ventilation, meaning tidal volumes were lower, meaning also that the SpO2 and end-tidal CO2 levels were better, and overall this resulted in a much safer way of mechanical ventilation. Second important thing is, not unexpectedly, if you have an automated switch from controlled to spontaneous breathing, we saw a much earlier spontaneous breathing with the automated mode of ventilation. Yeah, so this study has several limitations. First, it's a single center study. We need to perform this in other centers as well. And you could say the single center aspect is a problem because you had well-trained nurses, which actually can be explained in two ways. So you can say we had well-trained nurses and the machine or the automated mode of mechanical ventilation outperformed these nurses. So the effect can be much larger when you have less well-trained nurses at the bedside. The second thing is that the patients that were recruited in this study were not so sick, so they were more straightforward postoperative mechanical ventilation. While we know also in this group there can be more problematic patients in which you would like to see if these patients are also ventilated well with the automated mode. And finally, this is of course just a restricted group of patients, postoperative mechanical ventilation, while we have 90% of the patients are being ventilated for other reasons. So we need to check also in those patients whether an automated mode of ventilation is performing better than ventilation done by me and my nursing team.